Thank you very much, Monsen. Thanks for giving me the opportunity to present today. Let me quickly share my screen so you can all see the presentation. I hope it's popping up now. Fantastic. Yes, as Monsen said, I am delighted to have the opportunity today to present some findings and learnings from the long COVID study-a-thon that we had almost a year ago now. And as always, this was not only me doing that, there was a big effort of a group, and I'm presenting today on behalf of the team here in Oxford who hosted that. That is Kim Lopez-Guel, Frank Shea, Marti Catala, Danny Preter-Alhambra, and myself. So what was the motivation for this study-a-thon? There is obviously a substantial proportion of the European population that by now had caught COVID at some point during the previous year. And that means that long-term complications are becoming increasingly prevalent. So at the moment, studies suggest that about 1 in 10 people who had COVID do not fully recover from the acute disease, but present with ongoing symptoms or complications for 3 months or even longer. And at the time when we're proposing this study to the EHDEN Evidence Generation Fund, the post-acute COVID condition was not fully understood. So we thought it would be a good idea to do a network study and characterize long COVID and PASC in patients across Europe. And we did an open call to the community and presented the plan for the study, the protocol, and asked data partners to express their interest in joining. And it was wonderful to see that we had lots of people being interested, and all of them were able to run a bit of like a feasibility script at the beginning, so we could see if the databases would have the information that we would need for the study available. And in the end, we were lucky to have 13 database partners from 9 countries contributing to this study-a-thon. The study-a-thon was hosted in Oxford. You can see some of the pictures of the wonderful Worcester College that we were lucky enough to have as our venue for this week. And we had the great opportunity to invite 3 clinical experts who were working in long COVID clinics in Catalonia, who were there for us for the whole week and helped us to look at the data, interpret the findings, think about what kind of additional analysis would be helpful to really make sense of the data that we had to look at. The 13 data partners that I mentioned earlier came from basically all across Europe. We had data from Estonia. We had data from CPRD Golden Arm from the UK. We had data from the Hospital of Montpellier in France. We had quite a good representation of Spain, to be honest. That was great. We had some primary care data. We had hospital data from secondary care. We had data from the Netherlands. The IPSI database participated. I know that Njung will tell you more about the Norwegian data later, but it was wonderful to have her and the Norwegian health records participating in this study. And we had colleagues from Italy participating with the HSD data. And on top of these European data, we added 2 non-European databases, to be honest. So we had Pharmetrics Plus for academics, which is like US claims data. And we had colleagues from the Jeju University in South Korea joining with some of their data. So in the end, 13 databases from different healthcare settings, different regions, very, very nice representation. The project itself comprised 3 different objectives. So the first aim that we have was to describe the epidemiology of long COVID and post-acute symptoms. We wanted to characterize the population with long COVID or post-acute symptoms, and then think about if there are particular subgroups of long COVID that could potentially be interesting to identify for later targeting with specific treatments or preventative measures that could help these people to lower the burden of their disease. For the study population, we were interested in people who had a SARS-CoV infection or a clinical diagnosis of COVID, and we tried to disentangle a little bit if people had their first infection or if the infection was a reinfection. And the definition that we have was obvious. The first infection was like the first ever recorded positive test for COVID or clinical diagnosis. And then for the reinfections, we implemented a washout period of at least 42 days between one and then potentially the next reinfection, because obviously people who had an infection would test positive for a couple of days, and then we didn't want these tests to be considered a new infection, but kind of included this washout period. To give a bit of context, we also had control cohorts. So we had a test negative cohort, which we anchored around a negative test. We had a flu cohort, which was a historical cohort where we looked at people with a record of flu. And then obviously we had the general population in the database. As for the outcomes, we used the long COVID or post-acute COVID condition definition that the WHO published, which basically is a combination of like COVID as the infection as the anchoring event, and then they issued a list of 25 symptoms that were considered typical. 24 of them we could see in our data. One was post-exertional fatigue, which we basically included in our symptom of fatigue and malaise. So 24 symptoms. We then were interested in other post-acute sequelae, such as thromboembolic events or cardiovascular events, and other medical conditions that were previously described in the literature to be potentially of interest if they happened after COVID. There was uncertainty if there was an association, not, and that was, for instance, diabetes or other autoimmune conditions. We implemented these outcomes as kind of an algorithm. So the index date was either the positive test or the negative test or the flu diagnosis. And then we looked at the record of the symptoms or a disease diagnosis 90 days after, up to a year after. And to make sure that we don't consider prevalent conditions such as anxiety or depression as post-acute symptoms, we would implement a symptom-free washout period of half a year prior to the index date. So we would kind of we wouldn't consider prevalent symptoms as long. So the specific aims for the first part of the study was to estimate the incidence of post-acute symptoms, to look at the demographic patterns of these symptoms, and then compare the incidence among the affected, test negative, and the general population. And my colleague Frank was leading on this part of the study, and he presented this wonderful and very colorful graph here where you can see all the different symptoms that we were looking at and their incidence based on the settings, so primary care, secondary care, disease registers, or in this case, the Norwegian population-based registers and claims data. And I just want to quickly look at three of them in a bit more detail. And the first one is the any symptoms. So in this cohort, everybody who had like at least one symptom that was listed by the WHO would contribute, and we would consider that one symptom is enough to be considered having long COVID. And as you can see, the incidence per 100 person years in primary care varied between 25 and 40, which is obviously quite a bit of a difference considering that it's the same setting. But compared to, say, for metrics in the US, we did see a much lower incidence. We saw similar incidences in Norway and Estonia and the hospital. So that was quite interesting to see that the magnitude was fairly comparable. But if you look at specific symptoms such as cognitive dysfunction or depressive disorder, the incidence varies greatly with the setting. So, for instance, the cognitive dysfunction is something we saw more frequently in the secondary care databases compared to primary care, whereas depressive disorder was quite common in primary care and secondary care. We then were interested in comparing the incidence of these symptoms in people with the COVID infection compared to people with a negative test or the general population. And in this graph, you can see the rate ratios of comparing infection versus test negative and general population controls. And as you can see, most of the symptoms were not very specific for happening after the COVID infection. So in blue, you can see the test negative population, and in red, you can see the general population as the comparator. And only in the very last row for alter test and smell, you see that there is a clear significant association between the COVID infection and the symptom, whereas for all others, it looks like compared to the general population, everything is more common after COVID, and compared to the test negative population, most of them are not really more common after COVID, which means that it's very important to think about what the comparator control should be for a study like this. So the key finding here is that there is great heterogeneity in the presentation of symptoms across settings and data sources, and our meta-analysis suggests that most of the symptoms that were considered specific are actually not so specific. We only saw altered smell and taste being associated with COVID infection. That is in line with the literature that is out there at the moment. So I guess one thing that we can take for future research or as a take-home message is that the current WHO definition for long COVID is probably not perfect yet, and there might be the need to refine that and further evaluate this definition. The manuscript reporting on this study is currently with the co-authors. I've seen many of you in the call today. That's fantastic. So at the moment, we're reviewing this paper and hopefully can submit that to a journal soon. Another part of the study was looking at the disease burden in long COVID in the general population, looking at autoimmune conditions. And I just briefly want to show you this slide where Teresa Burkhardt was looking at postural orthostatic tachycardia syndrome and chronic fatigue syndrome in different populations across the databases participating in the study. And I think what's very nice to see here is that the incidence rates are very different based on the different settings and databases, but also depending on whether or not the definition was just based on the diagnosis and therefore fairly narrow, or including symptoms and then much broader. So I think this is, again, a nice example for heterogeneity and also considering the definitions of diseases and phenotypes when we do these kind of studies. So again, we found a high disease burden for autoimmune conditions and high heterogeneity. And Teresa did a bit of like accrued incidence rates to see ratios to see whether POTS and CFS were associated with COVID, and she found that the symptoms were a bit more frequent after COVID compared to an unmatched test negative cohort. So I think there is the need to further evaluate that. But it's the first study that is looking at these conditions in different databases. And I think this is a very interesting manuscript, again, that is currently under review with the co-authors. The last part of the study was looking at clusters of different symptoms among people with long COVID, and we used latent class analysis for that to basically understand if there are specific clinical presentations of long COVID that could be targeted for better treatment and disease management. So latent class analysis is basically a soft clustering algorithm that calculates the probabilities of belonging to different clusters and then assigns the patient to the cluster that they most likely belong to, and that is based on posterior probabilities. And we derived our clusters based on the occurrence of the symptoms, but also considered age and sex as additional covariates. And then we had to think about what was like the optimal number of clusters that we wanted to arrive at. And we made that as decision based on Bayesian information criterion, some classification accuracy measures, and then obviously we looked at the clinical relevance of the clusters that we came up with. And it turned out that 3 and 4 clusters were fairly comparable. So we decided to look at the 3 cluster because that was a bit more straightforward. This is the representation of the clusters, and I appreciate it's like a very big plot with a lot of information. So let me quickly guide you through that. So we have here in each of the rows one of the clusters, and each database contributing to this analysis had 3 clusters. So the first 3 rows are 3 clusters from Prometrics. Then we have 3 clusters from the Norwegian health registries and 3 clusters from IPSI, and so on and so on. And then for the conditions and the symptoms, you see them here in the columns on the right side of the panel. Each of the symptoms has like its own column. And then on the left side of the panel, you see a bit of like the characterization of the clusters. So we looked at vaccination, we looked at comorbidities of people in the cluster, we looked at healthcare utilization, so the number of GP visits, hospital visits, median age, distribution of sex, and the size of the cluster. And it was interesting to see that among the people with long COVID, most of the people, up to 70%, only had 1 post-acute symptom recorded in the database. So that means that many symptoms that we found, many clusters were characterized by only 1 symptoms, or at least like 2 symptoms that were highly associated. And the most, one of the interesting ones that we found that popped up quite often was joint pain. And I guess joint pain is something that is very common in the population. So it could just happen that we picked up the people with joint pain. And the other cluster that we found was recorded in more than 1 database was anxiety and depression, which is also a combination of symptoms that we would expect in similar. So we were interested in clusters that were not only recorded in 1 database, but kind of reproducible in different databases. So we tried to validate a little bit the clusters that we were seeing. Given that the 1 symptom cluster might be clinically not super interesting or telling, we also did an analysis looking at people with at least 3 symptoms. And that meant that only 7 to 10% of our long COVID patients were included in these analyses. And you might, in this plot here, miss Idol and Imas because restricting to this subset of the long COVID population, we didn't have enough individuals to include in this analysis for those 2 databases. However, as you can see in this picture, it looks a bit more bluish, and that means that we had more clusters that had multi-symptoms that are like popping up here. And we found basically 3 different clusters that occurred across databases. And the first one was, again, depression and anxiety. We saw that predominantly women were affected with a median age between 30 and 40 years, and sometimes also combined with symptoms like headache or fatigue. The second cluster that we found were gastrointestinal issues and abdominal pain. Again, predominantly in women, people were aged between 20 and 50 years, and we sometimes saw that they had fever, cough, or allergy. And then last but not least, a more respiratory cluster with cough, dyspnea, fatigue, and joint pain, again, predominantly women, but slightly older. The average age was between 50 and 60 years here. So that was the first study that not only looked at clusters in one database, but actually validated or compared them across databases, which I think is very interesting and useful. We saw that the single symptom clusters are common, but likely reflect symptoms with a high prevalence in the general population. And these complex clusters that we saw when restricting to people with more symptoms recorded might be more clinically relevant. So that work was led by Kim Lopez and Annika Jodicke. We submitted this manuscript very recently, so I hope that soon we can show you a bit more details and potentially have this as a preprint available. When summarizing the learnings of this study-a-thon, I think it's nice to see that it was a very large study coming out of this. We had more than 780,000 individuals with post-COVID symptoms. It was the first study to validate clusters across databases. And I think our study showed that there is a substantial heterogeneity, not only in the incidence of post-acute symptoms, but also in the clusters. And I think that means that the current definition of the post-COVID condition should be reviewed to reflect this clinical variation in the presentation. And I think it has not only been a very nice week sitting together in Oxford in the college, but also a lot of work preparing, running code, interpreting the data after. So I think it has been a really nice experience. And also I'm quite happy with the output because I think it's really important to show that things are not as easy as they look at when you look at one database and long COVID, but there is a lot of heterogeneity to take into account. So 1 week, 13 data partners. We have 4 abstracts and 3 manuscripts. And I'd like to close this presentation with a very big thank you to all people involved. I know many of you are on the call today. Thank you very much. And thank you to EHDEN for giving us the opportunity to conduct this study. I'm looking forward to your questions, and I'm gonna stop sharing my screen now. Thank you.
Thank you, Annika, for this presentation. Now that we are in the anniversary of the first lockdown, very timely to know these learnings. So, any questions for Annika? I don't see anything on the chat. Still, otherwise, maybe we can move to the following presentation, and maybe at the end of the session we can take also the questions for both of you.
Fantastic.
So then moving to Nunc. Nunc, are you still here, right?
Can you hear me now?
Yes, we can hear you.
Do you see my presentation
and
on the
we
screen?
see.
I hope so. Yeah.
Not on presenting mode still, but we can see.
Yeah. Okay. Hi, everyone. My pleasure to be today to present another piece of work with EHDEN colleague. And I'm presenting today on behalf of the whole group of people that I listed on the slide here on the expanding of the combinated model to support perinatal research in network studies. So the motivation to do this study is that understanding of the condition and the risk factors during the perinatal period is very crucial. But pregnant women are often excluded from the clinical trial, so most of the knowledge that we know about the effectiveness and the safety of medication used during pregnancy usually come from the real-world data. But the current, when mapping the data into OMOP, we at University of Oslo and also colleague at CDAP rely that the current OMOP combinatorial model lacks the structure to define the pregnancy episode. So we came up together and then going to propose a structure to define the pregnancy episode using our data. And also in addition, there are several pregnancy algorithms. A few of them has been validated using OMOP combinatorial model, but only for claims and electronic health record, and mostly in the US and UK. So we aim to define a structure of pregnancy episode and the associated information using expert-defined consensus. And then we pilot the implementation of these structure into two data sources with pregnancy-related data readily available. So the team that came up together include perinatal domain expert, epidemiologists, and data scientists from CDAP, UIL, University of Oxford, and also from Dundee with Daniel Morales. And our aim at that time to combine experts from different domains, because we want the proposed structure to reflect current clinical and research need in perinatal field. And also we want to take into account the data standardization and interoperability. And then we implement the structure in two databases, one from CDAP, and many of you here know about this about CDAP. I think CDAP is one of the databases that produce a lot of OMOP-related study. So CDAP is population-wide electronic health record database from Catalonia in Spain, compiling information of more than 8 million people from 2006, that covering 75% of the Catalan population. And according to many estimation, the population that represent in CDAP are representative for the overall Catalan population in terms of many demographic information, age, sex, etc. And then in addition, in CDAP, we have the detailed information of more than 40,000 deliveries per year, and the data are readily available to be mapped into perinatal expansion table. So that's why we decided to go with these database. And in addition, we also map the data from Norway, and I want to introduce you briefly here. So the data that we had in this project was derived from the National Population Registry, where we had 5.4 million inhabitants and approximately 900,000 pregnancy episodes. And this information was linked across different registries in Norway. It's at the national level. We have the data from National Population Registry with residency and demographic information. We also have consultation in primary care and secondary care. We also have information on prescription field in retail pharmacy, and especially we have very detailed information about pregnancy and birth. And I want to mention briefly here that we have all the recorded pregnancy in Norway. Those lasting longer than 12 weeks will be recorded in the Medical Birth Registry of Norway. And in addition, for the COVID-related research, we also have information on communicable disease, notification, and also information about the vaccination. And all these data are linked using a project-specific unique personal identification, which is very common in Nordic countries. And we were able to link all these data files that was subsequently delivered to our GPRD compliant environment for storing and analyzing sensitive data. And from there, we map our data into OMOP, and then especially for the perinatal expansion table, we use mostly the information from the Medical Birth Registry of Norway. And then we had a week of study-a-thon, is another study-a-thon on pregnancy expansion table. And during the week, we were able to create the two packages that allow us to test and also validates the structure of the perinatal expansion table that we develop, and in addition to describe the information that we had in there. Thanks to Ed and Teresa from University of Oxford. And the first R package that we created was called the PET diagnostic package. We call PET diagnostic package actually. And this package allows us to ensure that the perinatal expansion table that created for each of the data partner were implemented correctly and produce accurate results in each setting, meaning that we have exactly the same format that we expected, the name of the variable, etc. And this package includes a set of tests and queries that are designed to assess the quality and the completeness of the perinatal data captured in each of the table. And then I included in here the link to the GitHub where we make it available. So any data partner that have pregnancy-related data that can map into almost perinatal expansion table can use this package to test to do the quality control of their table. And in addition, we also created a PET characterization package that allow us to summarize and visualize information captured in the expansion table. And then these are the results out of our expert consensus discussion. We have, now I don't remember exactly how many meetings, but we have approximately 10 meetings that we go through each of the combinator model field that we propose with a description to decide whether that was required or optional, etc. That was, and the idea for the structure of these tables come a lot from the oncology extension table, I think that's how it's called. So we believe that for the pregnancy table, it's important to have the person ID, which allow us to link this table to the person table, and subsequently will be possible to link to other OMOP data field as well, like drug occurrence and visit occurrence, etc. And then we have a pregnancy ID that allow us to identify a unique pregnancy episode. And we also believe that the start date and the end date of the pregnancy episode is also important. So we require this field to be filled in the table. And these and the length of gestational in days is also important to be presented. And also the pregnancy outcomes we define in here, the live birth, miscarriage, stillbirth, etc., should be also present in the table. And the pregnancy mode of delivery, how the delivery was initiated, is also need to be present, and also whether the pregnancy was single or multiple. And then we have a couple of optional field that we believe that is useful for perinatal research, but we know that is not every data partner have this information, but at least we have this in the Norwegian health registry, and also partly in the CDAP data. So for example, whether folic acid was used before pregnancy, during and before pregnancy, and number of fetuses in age of the pregnancy, on whether the pregnancy was a result of the assisted reproductive technology treatment, BMI of the mother before pregnancy, marital status, etc. So these information are optional, but it's very helpful if you have these data and map into the table as well. And beside the pregnancy table, we also created an additional table that representing the characteristic of the infant that born, and also the features belong to the pregnancy episode. So we have the pregnancy ID that allow us to link these information to the pregnancy episode in the pregnancy table. We also create an infant ID to identify the fetus and infant in the given pregnancy. And information in here are the information that we have from Norwegian registry, and that time not available from CDAP, so we made these field to be optional. So for example, birth outcomes, birth weight, on whether the fetus and infant has the congenital anomalies, etc., and also other characteristics of the born infant. So these represent the characteristic related to pregnancy, and you can derive these table very easily using the pregnancy, the characterization package. And we have approximately 700,000 pregnancy in CDAP data and 750,000 pregnancy in the Norwegian link registry data. And we also have the number of pregnant individual of the mother of these pregnancy captured between 2006 to 2020 in CDAP and 2008 to 2020 in Norway. And we see that the gestational length are pretty similar between the two databases, but in terms of outcomes, we see the differences between CDAP in Spain and Norway, and I can explain this a little bit later later on in the graph, that why we see a higher percentage of miscarriage and stillbirthing and termination of the pregnancy in CDAP compared to UIO. And then we also see a very it's very obviously you see the difference in the mode of delivery between CDAP and Norway, that the approximately 30% of the pregnancy in CDAP was delivered using C-section. Why that the percentage, the same percentage for UIO, which is 7%. And of course, other characteristic is pretty similar. Single pregnancy is pretty much the same between the two database. And we have the marital status of the mother before pregnancy or at the time of the start of the pregnancy in Norway, but not in CDAP. And then we have the number of fetuses also different between the two database, and also parity as well. The information is quite different between the two countries, reflect a lot of things. It's also because of the number of pregnancy capture and the historical data on whether you have that. Otherwise, other information on pre-pregnancy BMI, etc., is pretty similar between the two database. However, we have much less missing data in CDAP for BMI, pre-pregnancy BMI. And as I promised before, I will explain a little bit about the differences between the pregnancy outcome in CDAP and Norwegian database. First, the graph in the left side represent the number of new pregnancy per year in the two database. In blue line, the CDAP, and then in red line is Norwegian database. So we see a decrease in the number of pregnancy by time during the time period. However, we see that more of it's more significant for CDAP data compared to Norwegian. And according to Talita, this decrease is expected compared to the national statistic. However, at the beginning of the period, we see a very substantial increase in the number of pregnancy that recorded in CDAP data. And this was reflect a little bit about the recording practice in the data set. And then on the right side, we present the distribution of the gestational length in weeks per pregnancy outcome. We have live birth, miscarriage, stillbirth, ectopic, and also unknown. And we see that in CDAP data, we have a lot of unknown outcomes that reflect a little bit that the pregnancy episode would derive from the electronic health record and is not necessary to be 100% complete. However, as I explained a little bit earlier in the data that we have from the medical birth registry of Norway, we only have pregnancy that lasting longer than 12 weeks. So that's why all the miscarriage that happened during the first trimester was not captured in our database. So that is why we see a very small percentage of pregnancy ended up with miscarriage or termination of pregnancy in our data. And that is why recently our colleague has developed and also validated a pregnancy algorithm that allows us to capture the pregnancy that happened during the first 12 weeks using our primary and secondary care. And these are a little bit of information in terms of trend in the mode delivery and the trend in pregnancy outcomes. And as we see in the table, the number of pregnancy that was delivered using the C-section in CDAP is much higher than in Norway, but we see that these have the tendency of decreasing in the recent years. And then in terms of pregnancy outcome, we don't see much different in here, and especially we in Norwegian data, we capture mostly the live birth. And these are the characteristics of the fetus and infant born from the pregnancy that we map into the pregnancy attention table. And this information is solely for Norwegian data because at the time that we mapped the perinatal expansion table, the linkage between mother and child in CDAP was not ready. So they was not able to map into the fetus infant table. And this is pretty much in line with the information that we had in terms of birth outcome that we had in the pregnancy table. But we had additional information on birth weight and also congenital anomalies and APGAR score, etc. So the take-home messages from the work that we did in here, that the pregnancy expansion table, we find very helpful to standardize the perinatal data across different data partner into the OMOP CDM. So we have CDAP with the electronic health record, and then from Norway, we have the health registry. And this is very, and we use the pregnancy expansion tables to facilitate the future network perinatal studies, and we are currently pilot these implementation, and I will tell you a little bit more in the next slides. And then we successfully implement these structure into the 2 large European database, but we wish to expand these to other database, other EHDEN partner as well. And then from the work, we were able to create 2 R package called PET diagnostic and PET characterization that allow us to test and validate a wide range of data type and sources into the correct structure, and also allow us to standardize the way that we summarize information in the expansion table. However, we also acknowledge that we had the 2 data partner that participated in this work is CDAP and Norwegian database, where we have pregnancy-related data as readily available for us to map directly into the pregnancy extension table. But for many other databases, for example, in CPRD and also other data partner where you don't have the pregnancy information ready, there's a really a very urgent need of a validated pregnancy algorithm. And then because of that, our next step is to adapt a pregnancy algorithm, I think that called Matchel and colleague, to Norwegian health link health registry at UIL, and also and then I know that this pregnancy algorithm was validated using US and UK data, but it was not validated in other settings. So we gave it a try and then try to adapt and also to improve this pregnancy algorithm in a way that make it can be applied to our database as well. And the preliminary comparison of this algorithm to the information that we have from the Norwegian registry, both from medical birth registry and also the information that we use a pregnancy algorithm that we recently created, we see that the number of pregnancy that captured by this pregnancy algorithm, this published pregnancy algorithm, is relatively low compared to what we expected, and also in terms of the structure. I mean, the number of pregnancy with certain outcomes is not very much in line. So we are working on that, and hopefully we'll have the result to present to you soon. And then we also try to implement the pregnancy expansion table using CPRD goal data and led by Teresa, because the mature pregnancy algorithm can be applied to CPRD, was previously validated using UK data, so we directly use the algorithm in order to implement the pregnancy expansion table there. And then we also have colleagues from Sweden, Frederick and Lee. I think they're also in the call today. And then the data that they have in Sweden is pretty much similar to what we have in Norway. They have all the pregnancy that lasting longer than 22 weeks. That's of gestation, and they will be also easily also able to easily implement the pregnancy expansion table. And then in May 2024, in 2 months, we will have another study-a-thon in Oslo where we will work on a multinational study on the uptake and effectiveness of COVID-19 vaccination in pregnancy that led by CDAP. And then in this study, we will include 4 data partners from Norway, Sweden, CPRD, and CDAP. But any data partner that have pregnancy information readily available to map into pregnancy expansion table are very welcome to join us for this study-a-thon. And then this is our acknowledgement to go to our colleague and also go to EHDEN for the funding to conduct this study. Thank you.